Good morning. Today, I'll be presenting on lasers and glaucoma management. So, as we all know, lasers have simplified the management of glaucoma to a great extent. So, I'll be dealing with the lasers one by one in the order of frequency, which it is used in the subspecialty of glaucoma. So, coming to laser peripheral iridotomy, which is the most commonly done laser procedure in glaucoma. It's a photodisruptive ND-YAG laser which is used in this for the treatment of pupillary block. And the indications include primary angle closure glaucoma, primary angle closure, some special situations in PSCS, and secondary angle closure glaucoma with pupillary block. So, indications of PI in angle closure suspects: patients who need frequent dilatations like diabetic patients, patients who are on anticholinergic drugs, type A personality and anxiety-related issues, those who are unable to undergo regular follow-up, and prophylactically in the other eye of PACG or PAC. While planning for YAG PI, you have to take an informed consent and explain that this is not for IOP control and explain the possible adverse effects that can happen and tell them that multiple sittings might be required in rare cases and they might be have to continue anti-glaucoma medications if IOP is not stabilized, and ask for history of use of anticoagulants. If yes, you may have to delay the procedure for 1 or 2 weeks and prepare the eye with pilocarpine 2% before the procedure. An Abram lens is used to get a clear view of iridotomy site, to get a greater focus of laser and to reduce collateral damage and to stabilize the eye and control bleeding and help to wash out pigments from the PI site to facilitate enlargement of the PI. And position, the initial teachings was to do it in the superior aspect in a portion well covered by the lid, but this notion does not hold true anymore, because the recent studies have shown that any position is okay, and preferably avoid supratemporal and supranasal area where the upper lid bifurcates. And you have to go for a thin area of the iris or for a good crypt. If it is in the inferior aspect, that is also fine, and avoid extreme peripheral crypts to avoid closure by the peripheral iris rolls after the effect of pilocarpine weans out. And avoid 3 o'clock and 9 o'clock position due to the presence of blood vessels and nerves there. Complications are intraocular pain, hyphema, dysphotopsia, and iritis, and if not done carefully, it can cause focal or generalized cataract, focal zonullar damage, DM detachment, endothelial cell loss, etc. Nolan et al. Found that laser PI leads to an increase in angle width by 2 Schafer's grade. And another study conducted by Hay et al. Found that mean IOP is decreased by only 0.2 millimeters of mercury for every 10-degree difference in angle width after iridotomy in primary angle closure suspect eyes. So it is not of much help in reducing the IOP. Coming to the next application of laser in glaucoma, that is trabeculoplasties. It includes argon laser, selective laser, and micropulse diode laser trabeculoplasty. This is an effective, non-invasive, and easy to perform technique to reduce the intraocular pressure, especially for those who are not compliant about anti-glaucoma medications. And this can be done when medical therapy is inadequate, as an adjunct to medical therapy, or as a primary treatment modality. Indications are primary open angle glaucoma, ocular hypertension, pregnant women, for those who are unable to undergo trabeculectomy, pseudoexfoliation, pigmentary glaucoma, and PAC status post PI. Contraindication: because this is a gonioscopy aided procedure, if there is an adequate visualization of angle structures, this is not possible. Also in contraindicated glaucoma associated with uveitis, trauma, and angle dysgenesis. So this is a table showing comparison of ALT with SLT. In ALT, 488 to 514 nanometer argon blue or green laser is used, whereas in SLT, frequency doubled ND-YAG of 532 nanometer is used. In ALT, we target anterior portion of trabecular meshwork, whereas in SLT, the laser targets pigmented portion within the irradiation zone. That is a pigmented trabecular meshwork. In ALT, the mechanism is to cause shrinkage of the treated areas and opening up of the untreated areas. Whereas in SLT, the initial laser injury triggers a cellular response and tissue remodeling, which facilitates greater outflow. And in ALT, post-procedure inflammation is very high, and we may have to deal with dexamethasone or prednisone and acetate eye drops. Whereas in SLT, milder steroids or NSAIDs will be sufficient. And the complications in ALT, we can expect high IOP spikes and PAS formation, which is not present in SLT. And retreatment in ALT is not possible because of high thermal damage induced in the first procedure, whereas SLT can be repeated, and SLT can be done in post-ALT eyes also. Future trabeculectomies carry a high risk in, high chance of failure in ALT patients, whereas SLT, this is fine. This is a picture showing the spot size, comparison of spot size of SLT versus ALT. The spot size of SLT is more, but the laser targets only the pigmented portion of the trabecular meshwork, whereas in ALT, the spot size is less and the power is more, and there is more collateral damage compared to SLT. ALT has been shown to reduce IOP and slow visual field progression in several multi-center randomized controlled trials, notably the early manifest glaucoma trial and advanced glaucoma intervention study. Also, the glaucoma laser trial also indicated that eyes initially treated with ALT have lower IOP and better visual field and optic disc status than the fellow eyes treated medically. So why we went for SLT? This table shows that IOP decreasing effect of ALT and SLT is almost comparable, but owing to the benefits which SLT has compared to ALT, that is less tissue damage, less evidence of pus formation, and more chance of trabeculectomy success in the future. Nowadays, SLT is performed and ALT is no longer done these days. And coming to the third modality, that is micropulse laser trabeculoplasty, indications are similar to ALT and SLT, and it has the advantage of having no visible thermal burns to angle structures, and it requires greater skill of surgeon because there is no visible mark created during the procedure. Micropulse is basically chopping a continuous wave into a beam of envelope of repeated short pulses. This is a picture showing comparison of the tissue damage produced by continuous wave versus micropulse. The second picture is a micropulse, and there is no evident damage to the trabecular meshwork after this procedure. So this is a study conducted by Sun et al. They compared micropulse laser trabeculectomy versus SLT. Success rates are comparable, and micropulse is to be considered in eyes in which IOP spikes cannot be tolerated. Coming to the next application of laser in glaucoma, that is laser cyclophotocoagulation. This includes transscleral, endoscopic, and micropulse diode. Basically, reduce aqueous production by destroying the ciliary body. Indication is for end-stage refractory glaucoma. Advantage is hypotony, vision loss, corneal edema. In transscleral, the probe is placed at the limbus and 18 nanometer diode laser is used. It can be done 180, 270 or 360 degrees, and 3 o'clock or 9 o'clock positions are avoided. The disadvantage is extensive architectural disruption of ciliary body, which may extend to pars plana and iris stroma. This is a picture post-procedure. In endoscopic, there is clear direct visualization of the ciliary body during the procedure, and it targets non-pigmented epithelium only, and there is no coagulative damage to tissues beyond the ciliary process. It can be done in as a limbal approach or pars plana approach. Advantage is less incidence of hypotony, phthisis, and severe vision loss compared to transscleral. Micropulse is again a transscleral approach, but there is less chance of collateral damage. It can be even used in seeing eyes, and there's less risk of hypotony. Next application is laser suture lysis, cutting the scleral flap nylon sutures post trabeculectomy. This will, the complications are in conjunctival perforation, flat AC, blood leak, prolonged hypertony, etc. Laser peripheral hydroplasty is used to widen the anterior chamber and break peripheral anterior synechiae in angle closure glaucoma, which are unresponsive to anti-glaucoma medications, in which there is significant corneal edema or shallow AC. Contraindications, non-visibility of iris due to corneal edema or opacity or flat AC. Endothelial burns, iris atrophy, and Urey-Zavalli syndrome are reported after this. Other less commonly done laser techniques are IND-YAG laser hyoidotomy in malignant glaucoma. Overhanging or avascular blebs can be treated with photocoagulative laser to produce superficial scarring of conjunctiva. And iridolenticular synecholysis can be done to break posterior synechiae, which causes iris bombing. Thank you so much.